Afternoon, everybody. Thank you, Dr. Jha, for the opportunity. I'll be talking about the additional information that we get from OCT angiography. OCT is the most widely used imaging modality in ophthalmology today. It is used for diagnosis, follow-up, and assessment of treatment response, as well as a biomarker in retinal practice. Limitation of OCT is in its inability to accurately image the capillaries, as it is based only on tissue reflectance. Optical coherence tomography angiography, OCT angiography, is an extension of OCT that uses motion contrast to visualize the blood vessels down up to the capillary level. In place of intravenous dye, OCT angiography relies on motion contrast to generate vascular maps. It captures the flowing blood vessels and generate variety of maps of vasculature at different levels of retina. OCT data can be viewed in NFAS, that is on NFAS, and the cross-sectional fashion with the functional flow data that is superimposed as color-coded on the structural B scan, as it is seen here. These yellow dots are showing that the flow is present in these areas of retinal layers. And these are the NFAS maps at different levels of the retina: superficial, deep, avascular network, and the choriocapillaris. To generate an image on OCT angiography, there has to be minimal amount of flow within the vessels to generate a differential image. If there is no flow, there will not be any image. Now, what are the advantages of OCT angiography over fluorescein angiography? The OCT angiography eliminates the need for dye, thereby reducing the injection-related complications. The major advantage with OCT angiography is that it eliminates the narrow window that we have there in dye-based angiography, because the dye moves very rapidly in the retinal vasculature, so we have very limited time to capture the relevant lesion. Whereas in OCT angiography, this is not the limitation. There is very limited concealment of the lesion because there is no fuzziness because of the leakage of the dye. The dye leakage in dye-based angiography many times covers the relevant lesion, and you're not able to see what is happening behind the dye. So there is no concealment that happens in dye-based angiographies. Another major advantage with OCT angiography is that you can visualize the changes in vascularization at different levels in the retina. At what level the vascularization is normal, at what level the lesion is present at different levels in the retina, you can very beautifully delineate with OCT angiography. As you can see, this is the fluorescein angiography picture. This is ICG. You cannot visualize the neovascular network as clearly as you can see in this OCT angiography picture. The network is very clearly visible with OCT angiography. Now, what do you see in OCT angiography? The patterns of abnormalities that are seen on OCT angiography are abnormal presence of flow, that is neovascularization. You can see here, these are the neovascular networks. Anomalous vessel geometry, the abnormal vessels, dilated vessels can be seen. You can also delineate aneurysms. You can also beautifully delineate the avascular areas, the areas of non-perfusion and capillary dropouts. Now, how do you analyze this OCT angiography? Now, on the left-hand side, the cross-section, there is cross-section of the retinal layers. These are the NFAS maps of vascular patterns at different levels of the retina. There's superficial, deep, and deep vascular plexuses. There is avascular complex and the choroidal layers. In addition to the slab-based NFAS angiogram, the OCT data can be viewed in cross-sectional fashion with the functional flow data. These are the yellow spots which are showing the functional flow. It's seen superimposed on that. So both these NFAS and cross-sectional views helps in making the correct diagnosis. In macular degeneration, we are mostly concerned with this avascular complex and the choriocapillaris and the choroidal vascular area, whereas in vascular lesions like diabetic retinopathy, venous occlusions, most of the changes are occurring in superficial layers. These are some common clinical situations seen on OCT angiography. The retinal vascular disorders are seen in superficial and deep slabs. It is an excellent tool for imaging the areas of ischemia and non-perfusion, as I have shown there. Detection of neovascularization, ability to image the deep retinal capillary network and radial peripapillary capillary, which is not possible with fluorescein angiography. There is a disadvantage that there is a limited field of view in most of the machines, and also it does not indicate, it can detect the neovascularization, but it does not indicate whether the neovascularization is leaking or not. Now, this is a diabetic patient. Here you can see these are the areas of capillary dropout and ischemia in the posterior pole. And this is the superficial layer, superficial vascular network layer. This is the deeper layer where you can see the vascular abnormalities also. And corresponding on corresponding OCT cross-section, you can see the flow pattern, and also you can see the anatomical changes, the morphological changes that are happening within the retinal layers. So this is a patient with the proliferative diabetic retinopathy. Here you can see this vitreoretinal interface is showing this yellowish color, which indicates that the flow is present here. And on the NFAS map, how beautifully it demonstrates the presence of neovascularization. But it does not indicate whether the neovascularization is leaking or not. This is a patient with central retinal artery occlusion, acute phase. There is no flow here. There is a retinal edema. And on the left side, this is a normal eye. Juxtafoveal telangiectasia or MACTEL is a condition which is a very, OCT angiography is a very useful tool. You can see these telangiectatic vessels are seen here beautifully. These are areas of non-perfusion, and this patient is developing this neovascularization within the retinal layers, and now you can see the exudation has developed. So it gives a very beautiful pictures of macular anatomy, what is happening in the pathological conditions. This is a patient of myopic CNVM. Here you can see this yellow flow here, and you can see the on NFAS angiography, these are the vascular networks which are present as myopic CNVM. Another patient with the vascular network and some overlying serous detachment, and on NFAS you can see this is the vascular network which is present in a myopic CNVM. Macular degeneration or age-related macular degeneration is one condition where the potential of OCT angiography, in my opinion, is best utilized in these days. It has a high diagnostic value in detecting macular neovascularization and choroidal neovascularization. This is a type 1 macular neovascularization which is present below the RPE. Here you can see this yellow flow on cross-section below the retinal pigment epithelium, and similarly on NFAS angiogram you can see the vascular network is present below the RPE. In type 2 NV macular neovascularization is present above the RPE, and this can be mixed or combined also. Polypoidal choroidopathy or PCV is a condition where there are polyp-like lesions, and you can detect the flow within these polyps, these thumb-like structures, and also in the branching network within this double layer sign. But since these polyps are generally low-flow lesions, sometimes it is difficult to pick on OCT angiography. But if you very carefully see these cross-section as well as the NFAS pictures simultaneously, in many of these cases, you can detect the PCV lesions also. Still, ICG angiography is the gold standard for detecting PCV lesions. This is an interesting patient where you can see the flow is present in this drusinoid lesion, but there is no fluid. These are the patients of non-exudative CNVM. They can only be detected on OCT angiography, and almost about 20 to 80% of these patients, they eventually convert to exudative CNVM. They need close follow-up, but no treatment until the fluid is developed. This is a similar patient of quiescent choroidal neovascularization, whereas choroidal neovascularization is present, but there is no fluid. Similarly, they are best found on OCT angiography, and both these quiescent and these are non-exudative CNVM, and they may both develop exudation at a later date. Fellow eye of exudative macular degeneration patients should be very carefully looked for, because about 6 to 20% of these patients who have exudative macular degeneration in one eye, they may have non-exudative CNVM in other eye. This is only possible with the use of OCT angiography to detect these lesions. And it is very easy to follow up these lesions, these patients repeatedly, because OCT angiography is a non-invasive procedure, and you can repeat the procedure as many times as possible, as required. So these lesions in fellow eye, which are non-exudative, may develop exudation at a later date. So they should be followed up very carefully. This is an interesting patient, 60-year-old lady. She had 6/9 vision, 6/9 partial vision in the left eye. And OCT angiography, there was no flow. And it was found that there was this hyporeflective space was developing in the fovea, but there was no flow. The vision was deteriorating, and the hyporeflective space was increasing with subsequent visit. So, considering this is a fluid, the injections was given, but on OCT angiography, it was found that there was no flow present. So, actually, it was a patient of adult vitelliform dystrophy, not a macular choroidal neovascularization. So, OCT angiography is also a reliable tool for confirming the absence of neovascular disease in some of the situations, especially also in chronic CSR patients. There are patterns, characteristic patterns of macular neovascularization, which can be detected with OCT angiography. They're helpful. These characteristic patterns are helpful in detecting how this lesion, how this patient is going to behave, and what modality should be used. Should I stop? Okay. So this is the patient who was injected with anti-VEGF injection, and you can see how this neovascular lesions are responding. Maximum regression occurs 2 weeks after the treatment, and reproliferation and reopening occurs. You can delineate between active and non-active lesions with the help of OCT angiography. OCT angiography also has a role in assessing the progression of dry AMD also, because there is excellent correlation between the fundus autofluorescence and fast OCT and OCT angiography for determination of geographic atrophy if it is extending in these areas. In future, this is for leakage. You can see whether the fluid is present on the OCT and OCT pictures, and if you find fluid, you need to treat these neovascular lesions. You have to understand how the various artifacts will influence your images. So you need to beware of these artifacts. OCT angiography is a useful technology. It is a dependable tool for assessing various retinal disorders. Thank you.